listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assist podcast with your host, Dr. Bill Evans. Today we're going to be talking with Kirk Wong, who's a pharmacist at the Juravinski Cancer Center. I'm going to find out a little bit about what he does and how he helps patients who are receiving their medications on an outpatient basis. But before we start that conversation, I'd just like to remind our listeners that the Cancer Assist podcast is brought to you by the Cancer Assistance Program, based here in Hamilton, Ontario. And the Cancer Assistance Program provides a variety of free services to cancer patients, including free rides, equipment loans, nutritional and incontinence supplies, amongst a number of other supports for cancer patients. And these podcasts are meant to be a kind of support as well, and they're made possible by generous donations from individuals in Hamilton. And we hope that by learning more about cancer and its causes, how it's currently treated, and the supports that are available in our community, that it will make the challenge of dealing with cancer just a little bit easier. So, welcome to Kirk Wong, who, as I said, is a pharmacist in the oncology section of the Hamilton Health Sciences at the Juravinski Hospital and Cancer Center. So, pleasure having you here today, Kirk.
It's an honor to be invited on. Thank you so much.
So, I thought maybe we'd start with just a little bit about the training of a pharmacist and then how you got to be an oncology pharmacist, because I don't think many people truly know the kind of training you go through to get to be a full-fledged pharmacist.
Yeah, I think that's a good question. Things have changed a bit since the time I went through school. So when I went to school, you had to do minimum 1 to 2 years of university and apply to the pharmacy program after completing those 1 or 2 years. And it was a bachelor's program. These days, it's what's called an entry-level doctorate of pharmacy, meaning that the degree will take 5 years to complete. There are practical rotations, and once that 5 years is complete, there is an option to conduct a residency. Now, there are not enough residency spots for all the pharmacists, so some will enter community practice right away, some will enter the industry, but the residency is not required. Although there are oncology-based residences, it's not mandatory to become an oncologist pharmacist. A lot of it is learning on the job.
Right. It sounds like medical school, 5 years of training. So is it you go into the College of Pharmacy, if that's correct terminology, and then do 5 years within a pharmacy?
Yes,
wow.
Yes, that's correct.
So that's quite a change from what it was before. And I guess that just reflects the increasing number of drugs, the complexity of therapies that are available pharmacologically, and the amount of information you have to learn.
Yeah, I think that definitely for very many years there was a shortage of pharmacists. And so when I went to school, there was only one school of pharmacy, which was University of Toronto. The University of Waterloo has their own pharmacy program now, and that sort of helped with the sort of labor demand in the profession.
Sounds like so many areas in healthcare generally that there's a shortage and that we need to expand. And so I was unaware that there was a pharmacy school in Kitchener-Waterloo area. So that's good to know. So you mentioned that you can do an oncology residency. And did you do that, or did you kind of slide into it from being a pharmacist working in the hospital?
Yeah, I sort of slid into it, I suppose. Back in 2012, the Hamilton General was opening an outpatient pharmacy, and I was a community pharmacist at that time, and I thought this would be a great way to enter sort of a hybrid between the hospital and community practice, where I see a bit of both. Patients being discharged out of the home, how do we transition to the community? At that point, the oncology world was starting to sort of pick up steam. It started to get a little more interesting with new drugs, and so I was asked to see if I could help out at the cancer center. And it was love at first sight.
And the rest was history.
That's
so
right.
around what time was that when you saw the changes in oncology? So when the molecular targeted drugs were coming in, all these oral drugs?
Yeah, I mean, there were already oral drugs, but you could tell from the clinical trials that there were more and more drugs coming down the pipeline, and they were going to get funded because of the evidence. And so that was around 2015 that I really noticed a lot of changes in the oncology space.
And it's becoming almost a tsunami of drugs, and I think it's very hard to, in fact, keep up. It's exciting times, and I'm sure it's exciting as a pharmacist to see the new drugs that are coming in. It's exciting to oncologists because they see the benefits to the patients, and I guess you see some of that too as they come back for refills on their medications.
Yeah, definitely. And I think one of the challenging facets of this is that as more and more drugs become take-home therapies, there's going to be your community pharmacists who aren't as familiar with these medications answering the needs of some of their patients who are receiving these. So we do try to serve a wide area, but we know that we cannot help 100% of our patients who pass through. There are community pharmacies involved. And so we take pride on educating patients whenever we can and caregivers about these new oral therapies.
I know that at one point, Cancer Care Ontario actually held a symposium about oral medication, in part because of what you described, the increasing numbers of them, but the concern about the safety of them, given the fact that they could potentially be distributed by pharmacists who may not be as well versed in those drugs, and hence the risk to patients of adverse effects, or maybe like so many prescriptions just get renewed at a certain point. But if you renew some of these agents and not on the schedule that was intended by the oncologist, it could be catastrophic. So is part of your work also helping to educate pharmacists in the community?
There is a little bit of that. I have, with some of my other colleagues, made presentations to our peer group, but as well to the Hamilton District Pharmacists Association, not about all these unique therapies, but about general good-to-know information pieces, so such as injections to boost white blood cell counts, for example, after chemo, and why they're being used, and how to know when, if there are no refills, you really need to call the doctor and make sure we don't leave this patient behind, because of the risk of admission when the white counts drop too low after treatment is quite a dangerous thing.
Yes, it's quite a different field of medicine, isn't it, from, I don't know, cardiology or neurology and so on. It's kind of this interesting high risk, high gain potential, but it does have to be carefully supervised, and hence why it's so important to have pharmacists like yourself who are well versed in these new agents and can monitor, along with the oncologist, that the patient's getting the right medication. One of the things that I think that pharmacists do much better than oncologists or other physicians is awareness of drug interactions. I know there always is the potential for different things and to interact in the pharmaceutical area, and patients don't just have one disease commonly, right? So that must be challenging to keep up with, or to even have the knowledge. What do you do personally to kind of make sure that we're not getting unusual interactions between some new cancer drug and maybe their existing heart pills?
Yeah, I think that's a good question. There's certainly those common ones that any clinician, after seeing enough times is fully aware of, but at least at our practice, when we dispense medications, we always run through a computer database of all the medications we know the patient is taking, so that we can say for sure the likelihood of these problems occurring. So that's one factor.
So there's a kind of search engine that will tell you if two drugs will interact?
Yeah, there's clinical references that the hospital subscribes to, and so we will put all the medications in there as best as we can. Now, in the pharmacy world these days, there is what we call polypharmacy, which is using multiple pharmacies. And you can't avoid that. patients have their own local pharmacy that they fill their regular medications at, and quite often they will only visit the cancer center to get these new specialized treatments that we are familiar with. So it's our job at the cancer center to really make sure that before we release it, that we've done our homework to ensure that there are no conflicts with whatever the patient is already taking, in addition to the physician, obviously. But it's best when both parties find themselves responsible to make
Double
sure
check on
nothing's
the
missed.
system.
Yes.
But how do you find out all the medications they're getting, including those that are being dispensed by retail pharmacists in their own community?
Yeah, so that's called getting a best possible medication history. You have the patient telling you exactly what they're taking. You have maybe a caregiver who also helps out with the medications, corroborating that. And we can always call the local pharmacy that the patient uses, as well as sometimes we are able to look into the ministry's billing to ascertain what's been filled. Now, what's been filled doesn't necessarily mean the patient is actually taking that medication. So then we always have to circle back and just double check, is this what you're taking and how are you taking it? Because that may also be different.
Sounds like detective work you're doing.
It's a little bit of that, yeah, that's for sure.
Now, your face sort of lit up when you comment about moving from the general and the outpatient or the retail pharmacy they were starting down there to oncology. What excited you about coming to an oncology setting?
I think it's a pace of change, and you're always at the forefront of all of these changes. It's funny, I mentor students, and sometimes they come in and I ask them, let me show you what you've learned in school so far, and I'll just point at the slide and say, okay, well, that is no longer relevant. There's new data out, and this is what we do now for these patients. And I think there's so much happening, and just is so exciting to be able to help patients.
So it's the pace of change, the new discoveries, the advances, it's really encouraging. And I'd have to agree with you because I'm a semi-retired oncologist now, but it is exciting to see the progress that's being made against cancer, and the results really are much more hopeful, and you're seeing it in the drugs that you're dispensing. Now, one of the downside of all the new medications is they're often very expensive, and if it's in the hospital, well, then the hospital budget's picking it up. If it's an oral agent, it depends on a number of factors, I guess. And I think that's another role where the pharmacists are really critical in helping the patient access some of these expensive medicines. I don't understand drug plans very well, but maybe you could give a high-level kind of view of drug plans, and then we'd like to talk a bit about what happens when patients really can't afford one of these new but very expensive drugs.
Yeah, you're very right in saying that these medications are often very expensive, and just so the listeners have an idea, it's not uncommon for some of them to cost $9,000 to $10,000 a month. And so when we think about how do we access these medications, that's really a role for our drug access navigators. And so the hospital outpatient pharmacy is very much like a community pharmacy in the sense that if anyone wanted to come by and fill a prescription for a common antibiotic or maybe a blood pressure pill, we could fill that, although we do cater to a very unique patient population. Now, what's also different is that our drug access navigators are 5 registered pharmacy technicians who know the sort of pharmacy world and drug plans in a bit of detail to help the doctors find out what will be covered by calling those drug plans. Now, let's say it's someone of a working age who might have private drug coverage through their work. We can find out what the coverage is. Is it a percentage? Is the patient going to be paying out of pocket, let's say 20% of the drug costs? And that can be quite stressful. When you think of 20% of a $10,000 drug, that's still $2,000 a month out of pocket. Even if it's a patient with a 100% plan, we would still find out if there's a lifetime maximum, are we going to exhaust this patient's coverage in a couple of months down the road, and how do we manage that? So there is a government drug plan called the Trillium Drug Plan that we always help patients apply for. Whether or not it's needed is really a question of looking at all the factors for the patient. Has the income changed so much so that the drug costs are a high percentage of family income? Is the 20%, for example, out-of-pocket costs still making up a large portion of that family's income? That is a government-run drug plan that is income tested. So the only requirement is that patients are up to date with their taxes. And we can certainly expedite the applications. So there's always ways to get drugs covered.
That's good to hear. I think a lot of patients would like to know that. There's always ways. I guess one of the factors we should make clearly, at least in Ontario, like if you're 65 years of age or older or on social assistance, then it would be covered. I think one of the big problems is younger patients. And of course, there's more than a few younger individuals who get cancer, and that's where it's really potentially a hardship if they don't have a really good drug plan through their work or high copay or factors like that. So in some provinces in Canada, it's totally covered if you have a diagnosis of cancer, basically in the western provinces, and Ontario and the Maritime provinces tend to be different and have this requirement around age, which is kind of unfortunate. But it certainly can put people in a difficult position of spending a large percentage of their income just to cover their drugs.
Yeah, you're right. And even with the cost of these medications, even if there is a really good drug plan or there is the Trillium drug application active, a lot of these medications do need a prior approval still from the insurer. So again, that's where the drug access navigators will come in. They will assemble the documents required and make the physicians' lives a little bit easier.
But those prior approvals take some time, doesn't it? And I guess that must be a high anxiety time for the patient and their supports. When is it going to be available? Because the doctor's ordered it. I've got cancer, and cancer is going to be progressing if I don't get on this medication quickly. And so what is the kind of time to get an approval for some of these things?
You know what? It varies. Sometimes through the Ministry of Health with their approval process, it can be as soon as 24 hours. The program is called SADI. I don't know too much about the mechanics, but I know that I have seen approvals come back within a day. The private drug world is a little bit different. But what I can say is that we very often can bridge patients, meaning that while we're waiting for these approvals to come through, we can minimize the delay by providing some compassionate drugs through our own pharmacy, right. Very much of the time, which is quite a unique service. Most community pharmacies will not be in a position to provide that level of service.
Oh, well, I know. Well, that's good to know, though, for cancer patients that there's a willingness to kind of bridge the medication. So that would reduce the anxiety I'm sure many of them would feel if they had to wait days to weeks to find out if they can actually get coverage for their particular drug. Look, we're going to take a short break now and hear a message from the Cancer Assistance Program, and we'll be right back with Kirk Wong talking about pharmacy issues in the oncology world.
We'd like to take a moment to thank our generous supporters, the Hatton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back with Kirk Wong talking about the oncology pharmacy, and we just had some really good information before the break that I think was probably very reassuring to people who may not have the financial means to access these new and very expensive drugs. the access to the Trillium program operated by the government of Ontario, the fact that approvals may be necessary, but the pharmacy at the Juravinski is prepared to provide some bridging drug while we're waiting for approval. And it sounded like the approvals often come quite quickly, particularly coming through the government. But we want to talk a bit about sort of the interaction with the patient receiving the medications at the pharmacy in the Juravinski. Patients come from across the city where we know we've got a lot of people with different languages, different levels of health literacy. And so that presents a challenge to try and inform them adequately so that they take the medications safely. And we know these medications have risks associated with them. They're not chemotherapy, and I maybe ask you to explain that a little bit further. But they do have side effects, and so people have to be very well informed about the potential harms. And so how does that all happen in a busy pharmacy? People from different cultures, languages, levels of health literacy. How do you manage all that? Sounds very complicated.
Yeah, that's a lot of topics there. But why don't we start with the first one? All these newer drugs that some of your medical oncologist guests have alluded to. How are they different from traditional chemo, right? So traditional chemo, whether it's given intravenous or whether it's a pill you take by mouth, it would go after any cells that are rapidly dividing and interrupt somewhere in the cell cycle, so that cells such as cancer that are rapidly dividing, they preferentially take up these nutrients, which is essentially the drugs that we give, and those drugs essentially kill off cells, but there's a lot of collateral damage sometime. And so, we always think about patients who have lost hair, for example, during chemo. That's one of the side effects of these drugs. Whereas these targeted agents, as their name suggests, is that they're targeting certain, for example, genetic changes in cancer cells. And so their side effect profile, although it's not as widespread, it still exists, and we always tailor our teaching to those medications and really drive home when the patients really need to call the doctor and when some of these side effects can be managed on their own if they're milder in nature. And I think a very good example of this is a lung cancer drug called osimertinib that Dr. Juergens had talked about. It's in a class of drugs that target EGFR. And without going into too much jargon, sometimes patients taking this medication will experience an acne-like rash. And so we give patients a cream up front, and we tell them, if you get a rash that looks like acne, don't go to the pharmacy locally and buy acne treatments. It's more of this drug causing it. This cream we're giving you is what you should use. And if it's milder in nature, use the rash. Use it to treat the rash, and if it resolves, then great. But if it becomes much more widespread, that's when you would call your oncologist. So little things like that are really important because patients need to know what to expect prior to taking these treatments. So that's the tailoring the teaching. But you also had another question about different walks of life and cultures and how we manage that.
Sorry about the too many questions.
And I think that with any situation, you just try to simplify your language a little bit and use visual aid props. The things I find most interesting in the pharmacy world is that when I teach patients, I actually have a prop in front of my hands now. I have the actual medication. So I can actually point to it and point on a calendar, for example, and say for the first 21 days, and point along the calendar, you're taking 2 tablets in the morning, and then I can motion to my mouth, and when you eat, right? And then 2 tablets in the evening. I say when you eat again, and you can use a clock to guide them. And then you sort of have to test their knowledge again afterwards and make them repeat back, but they're repeating back in their own language perhaps, or they're speaking through a translator. So it's really more of a gauging understanding exercise I think the how isn't so much of a problem usually.
But I'm hearing that you have to take the time.
Yes.
This is not a quick, here's your bag of drugs kind of thing. This is patiently walking through. I love the idea of having it repeated back to show that they've actually heard and listened and processed the information. Because these are drugs that are sort of in a class by themselves, right? That they're very valuable for treating cancer, but they're also potentially harmful. You know, the harms may be different from the chemotherapy drugs. There's still potential harms. So getting them to take that just by the schedule that they're supposed to take, it's 21 days, not 12 days or whatever. They're all different. What about compliance, that knowing that the patient's actually taken the drugs that they should have? How do we know that they've truly followed the directions you've given them and the oncologist has prescribed?
Well, that's a very good question too. And part of the teaching is giving maybe a diary for the patient to keep track of taking it if there's that concern. It may be unintentional, so part of the teaching is, what happens if a patient does miss a pill? What if the patient took the medication but had a bit of nausea and vomited, half an hour later? Does the patient take another dose? If the patient missed a dose, do they double up the next one? And those are all no.
Oh, good to know.
You don't do that. When in doubt, you don't do it. But for example, if it's nausea and if it's something that seems like it's happening with each dose, then we can give anti-nausea medications up front. And we commonly do for those treatments that we know do have a high rate of nausea. We do tell patients to take pills to treat that up front rather than waiting for it to become more serious.
And I think one of the things we should probably say is that the drugs that are available to control nausea today are so much better than in the past. I think that there's probably a lot of people who still have heard that chemotherapy made so-and-so their late uncle very sick and it was a terrible experience. Those sort of ideas linger in the community, and the anti-nauseants that are available today are pretty remarkable. That doesn't mean they're perfect, but they're pretty remarkable, and side effects can certainly be minimized and much better controlled than in the past. So fear of that should not be a factor in people's consideration about whether to take therapy or not. Any issues about how drugs are handled in the home, like in terms of safety and special ways of storing them, or what is there any advice to be given around those sorts of things? I particularly think about safety if there's children in the home, and how to make sure that the kids don't end up taking grandma's anti-cancer drugs.
Yeah, I think that's a good point. First of all, any medication, anti-cancer or not, should really be kept in a safe place out of reach of children, first and foremost. Now, because these medications are still hazardous, despite the fact that it's technically not chemotherapy, we still have to treat them as hazardous medications. So if it's a caregiver helping, I normally suggest not handling the pills with their bare hands. If they come in a blister foil, maybe you can just pop it out of the foil into a little medicine cup before handing it, to your loved one. There is the matter of what happens if there's soiled linens, and maybe that isn't something that your listeners are thinking about right now, but anything we consume, food and medicines, will end up in the toilet bowl, either in the urine or the feces. And so we always inform patients to close the toilet lid and then flush a full flush. Twice for patients who are on active chemo, but I still like to recommend at least a full flush for those who are on these targeted treatments. And then for laundry, if there are soiled linens, you should wash the soiled linens on their own with a long wash cycle. Really shouldn't mix it in, with everyone else's laundry. That's not.
makes sense too.
dirty.
But one thing that you said that caught my attention is putting down the toilet seat when you flush. And the reason for that is?
You don't want splashes.
You don't want splashes. And during COVID, there was actually articles about a vortex that's actually created when the water is going down the toilet, but it actually causes an aerosol that goes up. So in fact, you could be, hate to think of it, inhaling chemotherapy or molecular target agents in very small amounts, probably not terribly important, but still in all, it's just makes sense to not expose people who don't need to be exposed to these things. So the vortex, beware of the vortex in your toilet bowl and put the lid down. You did talk about the challenges of communicating in other languages because we have such a wide variety of people from all over the world and living in Hamilton. So how did you manage the best communication, particularly if you don't have staffing who speak the language of the patient who's in front of you?
Yeah, it's certainly very tough sometimes. You really need to take the time. And as I mentioned earlier, visual aids is really important. So just giving the main important information that you want up front so that at least the patient knows how to take the medications, I think is the most important thing I'm worried about first. Missed doses are really important. And then there is the matter of, is it taken with food or without food, and what foods to specifically avoid. So one of the classical drug-food interactions is actually grapefruit juice. And listeners are probably fully aware that if they're on a cholesterol medication, they're advised by the pharmacist never to have grapefruit juice. And it's not to separate it, it's not to have it ever, because the effects of the grapefruit will persist in the body and affect how the body handles a medication. In the case of some of these new agents, if it's something such as, let's say, a leukemia medication, and the grapefruit juice is consumed, there is a risk of toxicity because it's going to cause some of these drugs to linger around in the body at much higher concentrations and for much longer than had that grapefruit juice not been consumed. So really telling patients what to avoid and how to take the medication is upfront the most important piece of education that I give.
Well, I've learned something there that I didn't know as an oncologist. So I'm sure there's a lot of people that didn't know about the impacts of grapefruit juice on some of these new cancer therapies.
And it's not just limited to grapefruit juice. An arborist or a botanist probably give you a better explanation, but Seville oranges, which is used to make marmalade, exerts the same effects as grapefruit.
Really?
So we tell patients no marmalade,
no marmalade as well,
no Seville oranges.
So these are the subtleties of the art, or
there's nuances.
Yes, for sure.
And then if I'm counseling someone, from Asia, I would have to throw in pomelo into the mix and tell them, don't have a pomelo because that's like a grapefruit. So all sorts of tidbits that you pick up.
Yes, these are the important tidbits, in fact, to make sure that the therapies work optimally. Otherwise, you may be negating the benefits of the prescription you're getting. Now, you must also see patients who are on clinical trials who are on some of these agents too. So is any of the processes different when you're managing the patient on a clinical trial, studying the effects of a new targeted therapy, say?
I'm actually not involved at all with clinical trials. So I don't know what the workflow looks like, although I imagine that in a clinical trial setting, it is very controlled in manner in terms of education, in terms of lab work. What I can give you a little color is something called special access program drugs, which are those very often that are now off clinical trials in other parts of the world and have great evidence for, but the Health Canada approval has not yet been submitted, or it's in the process of. And so a lot of these drugs that have come off trial, and maybe the patients at the center were part of those trials too, we can still access through the drug access navigators. So I'm glad you brought that up. So the other interesting thing is that once in a while, we also use drugs off-label. So for those listeners who are wondering what that means is drugs that we use for other cancers other than the one that it went to market with. So you had Dr. McWhirter talking about melanoma and how there's BRAF medications to block this certain genetic aberration. And we have used this through compassionate means to treat hairy cell leukemia and thyroid cancers that have this genetic mutation as well. And so this has been the most interesting journey, finding that, hey, as a pharmacist, there's actually this molecularly based medicine that we're seeing now, which is, exciting to me.
And if the drug is going to be used off-label, what does that mean for you in terms of, do you have to get special approvals, or how does that work?
Yeah, definitely. Very often, the private insurers and the government insurers will not cover drugs off-label. So it's essentially on a compassionate basis only. And the drug access navigators usually try to request supply from the manufacturer on a case-by-case basis on compassionate means.
And does that mean that they sometimes provide it free, or do they provide it at reduced costs, or how does that work?
Very often it's provided free because I guess someone in the pharma industry can give a better explanation, but they can't be seen as promoting a drug for purposes that did not enter
approved
market
by Health
with.
Canada.
Yes. So there's no charge. It's just paperwork trail that needs to be followed.
Well, we've covered a lot of ground here. So I was very surprised when we started the conversation about the extent of training that's required for a pharmacist today, and then the additional training in oncology as a residency, and so it's sounding so much like the length of time it takes to train a doctor. So, but I guess of necessity, the complexity of pharmacy is so increasing that it's really necessary, and it's fascinating to learn about the various ways in which you're informing patients. I really liked your description of how you use the visuals to really help instruct the patient in how to do things appropriately, safely. And clearly a lot of effort goes into ensuring that the patients get access to the drugs they need, even if financially it's going to be a burden to them. Are there any things we haven't touched on in the conversation thus far that you think our listeners would like to know about oncology pharmacy?
Not so much oncology pharmacy, but just some good things to keep in mind, that at your appointments to have a good, really functional conversation with your oncologist is to find out, ask the questions of when should you call, what should I look for, or, what sort of symptoms can I manage on my own. And really it's all about empowering the patient, because at the end of the day, if you're on some of these newer drugs and you're taking it at home, you have to be your best advocate, and you have to be the one watching out for how things are changing compared to before you started the medication.
So that's good advice. Maybe a good place to stop and have our listeners think on those things. I really think it's been very informative. I learned a number of things out of this today, so I want to thank you very much for your time, Kirk. It's been very instructive and very practical. And as we close out today's podcast, just like to remind our listeners that they can listen to previous podcasts that we've done at the Cancer Assistance Program's website. That's cancerassist, one word, .ca. There's over 40 podcasts there covering a wide variety of different tumor types and treatment interventions and supportive care services here in the Hamilton area. So again, I want to thank Kirk Wong for his expertise and today, and all the things we've educated our listeners about in the world of pharmacy and oncology. Thanks very much.
Thank you for inviting me onto this. It's been a real blast.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.